Hello, everyone. I'm Traci Arieli, end of life doula and the founder of Comforting Closure. Welcome to another episode. Picture this. You're in a hospital room, a loved one is in bed, machines are beeping, the staff is moving quickly. A doctor turns to you and other family members and asks, "Do you want us to do everything possible?" Everyone looks at each other, unsure. No one even knows what everything possible really means or what your loved one would want. And you might think I'm sharing the scenario to be dramatic, but it's not unusual. I've been a witness to it. This is what happens when there isn't an advance directive or when an advance directive hasn't been discussed. An advance directive is a legal document where you write down your wishes for medical care and name someone you trust to speak for you if you can't speak for yourself. It gives guidance in those stressful, often chaotic moments. It also gives your family peace of mind because they'll know your wishes. And it gives your doctors the direction they need to treat you in a way that respects your values. But here's the thing. Filling out the form is only half the work. The other half is talking with your doctor about it, making sure they understand what matters most to you and what you mean when you make choices about things like CPR, ventilators, or feeding tubes. That's what today's conversation is about. How to prepare, what to bring, and how to ask your doctor the right questions so your advance directive truly reflects you, not just a piece of paper, but a guide for care. So grab a warm drink, find a comfortable seat, and join us for the conversation. Eleanor, welcome, and thank you so much for being here today.
Thank you. Thank you so much for having me.
Can you share a little about yourself and what did you see that made you think people need a better conversation about creating their advance directive?
So just a little bit of background about me. I'm Eleanor Tanno. I'm a practicing primary care physician. I was trained in family medicine, and I have a practice in Rockville, Maryland. And the way I got involved with advance directives is that way back when I was in the hospital, we would admit patients to the intensive care unit and they would be really sick. And this was the first time we were meeting them. And a lot of times they were not even well enough to communicate anything from their end. You know, they were either already on machines, not able to speak, or they were too sick to speak. And so we would turn to their loved ones, the people at the bedside, and say, did you guys ever discuss end of life wishes? What kind of medical care would your mom or dad or whoever want in this intense sort of setting? And the vast majority of times, people would not have discussed it, or they would have discussed it, but it was an advance directive document that was, ages old, or if it was made with an estate attorney, when they were 50 years old and now this patient is in their late 70s. And I thought to myself, I don't know why, as physicians, we leave these discussions to outside people, mostly to the estate attorneys, who are doing a great job, that most people who have an advance directive have documented with an estate attorney, but that doesn't have the nuance that we then need in the hospital. And I thought, as a physician, we should really be guiding these conversations, we should be initiating them, and we should be empowering people to have these conversations with their loved ones, and then also we should facilitate them. So I made it my mission when I left the hospital, to have these conversations in the outpatient setting, within limits of time, which is always a limit in primary care. But that is how I got involved with advanced directives to begin with. And now now that I'm in practice, I do discuss these things with my patients, but I realize there's a lot to discuss. So I offer a lot of courses in the community. I do a lot of teachings. And I have an online course that people can take if they're not local to the Washington, D.C. area.
So let's start with the basics. From your perspective, why is an advance directive important?
It goes back to updates in modern medicine. So essentially, not even that long ago, 100 years ago, when somebody got sick, they died. I mean, that was the trajectory. Somebody got sick, they got pneumonia, they either got better within a few days or they'd pass away. And within the last 100 years or so, we've just come up with really amazing advances in medical care, specifically life support. So ventilators, dialysis, all of these things that allow us in the right setting to give people quality of life and lengthen life. But in the case of advanced illness, advanced age, unfortunately, a lot of these treatments have really just prolonged the dying, right? We take somebody who is at the end of their life, 90 years old, has dementia, has kidney failure, and we're doing things to them that just sort of prolong the inevitable. Um, and so an advance directive is really a conversation that is then documented that it basically gives permission to those around you to stop doing aggressive medical care when it is no longer of really adding value to your life. And so without it, families tend to do, and I say families, but that's your medical decision makers. They tend to do more when they don't know what to do. They tend to do more aggressive interventions because of a sense of guilt and wanting to keep people alive. But the advance directive gives people permission to say, my patient or my family member would not have wanted this kind of care. And that's really why this document has become so important. So it basically gives them that that out, to say this is the end, this is the last thing we should do.
Before I became a doula, I never had a conversation with my doctor. I didn't even know what an advance directive was. A doctor never brought it up. My primary physician never brought it up. And the only time I kind of heard about it is when I had surgery, and then they would have me fill out, probably a pulsed, they'd have me fill out because I was going into surgery, not a true advance directive, but it never said mentioned anyone. So, um, so let's talk about that for a second, and then let's talk about how can we uh, get our doctors involved. What should we even do before we walk into the office and when we walk into the office? So why do you think it's the doctors are have a difficult time with this one?
I think so I think there's kind of like two stages of life, and I think in a young healthy patient, this conversation, it's just so hard to have a conversation about advanced directives because the possibilities of healthcare are just so unknown, right? So if somebody's healthy, contemplating what might happen to them in 30 years or 40 years or whatever, it's just not a very productive conversation. Also, in a young, healthy person, you're going to do aggressive medical care, right? Like if a 25-year-old has a seizure in a pool and drowns, and somebody calls 911 and they're brought to the hospital, you're going to do CPR, you're going to do all those things. Whereas if a 75-year-old patient with advanced colon cancer has a cardiac arrest at home, it's a very different kind of conversation, or a very different approach, I'd say, to medical care. So I think in young people, or I don't want to say necessarily young people, just healthy people, younger healthy people, the point of an advance directive is just to name a medical power of attorney and give the gist of the kind of medical care you would want if something would happen to you unexpectedly. As people get older, and this comes to the doctor, like as a doctor, as a physician, I have a million things to talk about during a 35-year-old's, wellness exam. It's way more important for me to focus on pap smear vaccines, all those things, at that point than an advance directive. However, I would say where doctors fail, and I don't want to criticize my colleagues because we are all, I believe, working, to the best that we can do in the time that we have with patients. But as patients do get older and do get more chronically ill, they don't always recognize it, but we can see it. We can see it down the hall. They walk in slowly with a walker, with an aide. They're coming in because they were in the hospital for the fourth time that year. Yeah, I think it is our job to say, hey, look, you've been in the hospital 4 times this year after falls. If one of these times you fall and you really hit your head and you're not able, you have a brain bleed and you're not able to make decisions, have you talked to the people around you about what kind of care you would want? So I think there's kind of like 2 scenarios, the young, healthy patients, and then the ones where like the writing is on the wall that their illness or their age is advanced. So if a young, healthy person were to come to me and try to have this conversation, I would probably say the most important thing for them is really to name their medical power of attorney, and their medical decision maker, and document that if it's not the natural order of succession, which in most states is a spouse followed equally by adult children. If they don't have that, that's sort of the default. So that's what I would say with a young person. So I think it's kind of important just for you, like if you came, I mean, I don't know your health history, but if you came to my office, and I wouldn't necessarily spend time talking about an advanced directive with you. Where it is important is patients who are later in life, and I don't have an exact age, but I would say, maybe if you haven't thought about an advanced directive by 70, it's a good idea maybe to at least open a conversation. But in terms of how to prepare for this conversation, so you come to the doctor, um, and do you want to get like all? I mean, do you want me to give you like a whole step-by-step guide here? Sorry, I don't mean to like interrupt myself, but because I could talk for like 20 minutes here, and I want to just make sure that I don't just get into too much without specifics.
Yeah. Yeah, don't go into too much yet.
So what I would say is if you are preparing to go talk to your doctor about your advanced directive, so say you're in the mindset, you've been thinking about it, the first thing I would do is schedule an appointment specifically to talk about this. So the reason for the visit with your doctor should be discuss advanced directives. And that's so that, one, you have time, and two, so that the doctor knows that's why they're walking in the room, because it really helps us to orient ourselves. And understand that most doctor's appointments, most primary care doctors probably have about a 15-minute slot for you. Some doctors might have 20 minutes. Rarely people might have more like 30 minutes, but most of them are about 15 minutes. So it helps to know going in that you're having this conversation, and that's the only thing on the agenda for that day. You can't squeeze this in. So I would book an appointment just to talk about the advanced directive. I would have that as the reason for the visit. And then what to do going in. So anytime you want to have a discussion with somebody, it really helps if you've done some preparation beforehand. So one thing I would do is think about who would be your medical decision maker, your medical power of attorney. And then the second thing I would do is review your state medical advanced directive form. And you can get this on the ARP website. They have a list by state. You can also just Google your state advanced directive. So in Maryland, I would do like Maryland advanced directive. And then it helps sometimes to put the word PDF in there so you get an actual document, not just like a series of links. And actually look at your state advanced directive. So that way, when you're going into this appointment with your doctor, you've read the document, you kind of even know what it says. You don't need to understand it all, because a lot of it does feel very medical and legal jargon, and so it's hard to understand, but at least have an idea of what this document is. And so think about who would be your medical decision maker. And then the second part of the advanced directive, besides naming somebody, is documenting your medical wishes. And I tell patients, don't get into the weeds here with this. Just think about values. And when I talk about this in courses, I call it the litmus test. So this is, I would want to be kept alive, as long as I am still able to blank. And for some people, that is a physical thing. Like, I want to be able to get out of bed, walk my dog, take care of myself. Other people, it's more social. I want to be able to have a conversation. I want to be able to recognize people around me. Other people, it's almost like a matter of, they use the word dignity a lot. Like, I want to be able to get myself dressed, give myself a bath. So think about, that's the litmus test. I would want to be kept alive as long as I am able to blank. And between that piece of information and thinking about who would be your medical power of attorney and looking at your state form, you would go into that conversation with your doctor pretty well informed. And, with most advanced directives, most states, you don't need a doctor or a attorney to sign these forms. They're just witness. So this is really just a conversation between you and the doctor. And the goal at the end of it is not necessarily in 15 minutes to have a signed form. It's just to make sure that you're not missing anything, big in the picture. Like, if somebody has an end stage illness, it's very different to have this conversation with that patient versus somebody who's, just starting to think about these kinds of questions.
Yeah, it's interesting that you say, use example of, with someone like me, you mention having a power of attorney, healthcare power of attorney. And then when you're older in the 70s and you really start going into, hey, fill this out, and this is what's important. I tell people, originally that a good time to start having these conversations about this about what these things are, and about the about this is when they are getting their driver's license and saying, "Hey, organ, here's the organ. You're going to donate your organs." Then start, yeah, this is, there's this thing called, advanced directive. This is what's on it. And this is what I would want as your parent. Just know that, this is something when you hit 18, you should think about just having this because you're going to be an adult then. And because of HIPAA laws, it's not automatic that the doctors will know to contact me. And that should be something also that when you go to your doctor, that they know kind of your lifestyle, and they know that, perhaps that's something that's important to mention to that, and other health, other lifestyle, uh, you know, your other lifestyle events or things that you do, perhaps.
I totally agree. I mean, everyone, you're right, as of 18 should have an advance directive, should have a named power of attorney. I see a lot of parents whose, children were hospitalized in college with mental health issues, and they may or may not have easy access to guide the care at that point. So yes, everyone should have an advance directive starting at 18. I think I'm thinking more in the context of like, when should you discuss this with your doctor? And I think for young, healthy people, generally the goal is to restore quality of life as much as possible, as aggressively as possible. Whereas in certain patients who are reaching the end of life or the end of their medical illness, the goals change. The goalposts changes. What are you trying to do here? And that's where these discussions become so important and so nuanced. And when these patients show up in the hospital and don't have an advance directive and have never talked to anyone about it, that it becomes like so heavy, because it just seems so obvious that this patient is not benefiting from certain kinds of medical care that we're offering. And, everyone wants guidance to make sure that they're doing the right thing.
Yep. Thank you for that clarification. Now, many people, when they walk into their doctors, I see, one or two things might happen. First, they might get really shy and not know how to start the conversation, or they want to be a good patient. And so everything's perfect, right? I'm sure you see that all the time. So if, how should a patient even start the conversation? I mean, they hopefully they've told the doctor, they've told the office, yes, this is why I'm coming in. But when they enter the office, how can they kick off that conversation? What should they say?
I think just leave it open-ended, I mean, just say, hey, I'm here to talk about my advance directive, and kind of go from there. It's helpful to know why this is coming up. Like,
Mm.
a lot of patients, it's just on their mind because they're at the age where people around them are having a lot of issues, and so it's just on their mind. But if they have a specific fear, it's helpful to know. But I would say you just start with an open-ended conversation topic, and let the doctor guide you, because depending on your health history and conditions, this might be a very different conversation from somebody else. So I would leave this in the doctor's hands, just to say, hey, look, I wanted to talk about this. And then if there's a specific reason why, otherwise, just go ahead and get started and let them start the conversation.
As a
But this
doctor,
is where it helps to be like prepared, like having thought about the who's your decision maker, and then think about your medical wishes in advance.
okay, great. So let's talk about that person, the POA, the healthcare power of attorney,
Yeah.
or the healthcare representative. It's called, healthcare power of attorney, healthcare representative, healthcare agent, healthcare proxy. They're all the same thing. So, how does a person choose a good healthcare representative? What
Yeah.
advice do you have? Because I've seen it
Um,
all.
yeah. So, first of all, I didn't know this, but when I started teaching, I realized that for patients who don't have an obvious person to ask, this is a huge source of anxiety. So about 20% of people don't have an obvious go-to person. And if you were in that 20%, that is okay. Like, we can figure it out together. So the default, most people would choose a spouse. And that's just because just the likelihood they're going to be the one at the hospital with you. And then if not a spouse, the next default, if you haven't named somebody, is adult children over 18 equally. And that's important, as a little like nuance, because you may or may not have one or more children who might be better or worse suited for this job. So if you're not going to pick anyone, that's sort of the order of succession that happens legally in most states. If you are going to pick somebody, I would pick somebody who is probably going to be there physically. It does help to have somebody in the hospital, but we do sometimes, as doctors, call, long distance to talk to somebody. But you want to choose somebody who's going to be there, somebody who knows you, somebody who will follow your medical wishes. That's a big one. So you want somebody who, in a chaotic situation, can stay somewhat grounded and can act on your behalf, because really you're appointing them to make your medical decisions. And so sometimes people will say, I want to have as natural a death as possible, but I know that my husband would keep me alive forever. So therefore I have named my adult son to be my medical power of attorney, because I know that my son could be, could better enact my medical wishes. So that's, I think, sort of like how I would get started. And then there's nuances from there. Another thing to think about is when you have these discussions, because you can't just write down your advance directive and expect anyone to know what that means. You need to have a discussion with them. When you have those discussions, not only do you want to discuss your medical wishes with the person who you have named as your medical power of attorney, you also want to discuss it with anyone who thinks they might be involved at the end of life. So in that case where, say, you appointed the son over the husband, you would still want to discuss it with your son, with your husband, right? Because you don't want anyone to be caught off guard. And you would want to discuss with, say, you have a daughter too, who's not named as the primary medical decision maker. You want to make sure that anyone who comes to the hospital who's there is not, you want to make sure everyone is on the same page. Because the last thing you want is arguments, guilt, uncertainty, sort of like not really having a productive time in the hospital, because that's just really hard for everybody. And it leaves a lot of guilt. Like I have patients who they don't speak to their siblings now, 10 years later, because when their mom died, things were just really ugly. And nobody wants that situation.
Yeah, I love how you gave that as an example, because my brothers, and I have two older brothers, our parents are amazing. And they sat us down and they took us through their will. Then my oldest brother said, "Oh, that's great that you've, thank you. Do you want CP? Like, what do you want? Life sustaining measures? What, if you're in the hospital, what do you want?" My parents hadn't even thought about that. They don't have an advance directive. I think I mentioned that to you before. They don't want those conversations. And so I said, the things, that's fine. We're not going to break up as a family and stop talking to each other because I didn't get grandma's blanket that she crocheted. But if you guys are in a lot of pain and Mark and I aren't aligned and we're arguing over, he wants to keep you on the machine, the ventilator, I don't, that's something that has the potential to break up a family. That's major. To see your loved one in pain like that and not to know. So I love that you mentioned that in reality, this does happen a lot, that people who don't talk about their advance directive. And when I work with people, I talk to them, I bring in their power of attorneys, and then I have a conversation with their families. Um, and not to say it's the most comfortable of conversations, because no one likes having these conversations. I don't like having these conversations either, but about myself at least. But the relief that everyone feels after these conversations, you could see it on their faces. You can just see it in their body language. They're like, okay, now I know. Now this is all fine. So it's a relief.
Yeah. And I just want to say, with those conversations, it's not even necessarily the decision that comes out of that conversation. Like, do you want CPR? Do you not? Because the truth is, out of a medical emergency, it's very hard to make those kinds of calls. But what happens is people discuss things in a way that I call them these pearls that come out of it. So what's helpful there is that, for example, like I haven't, with my parents, we've had conversations about end of life care. And both my parents, fortunately, are very healthy currently. And my dad says something like, Eleanor, just shoot me. Just shoot me. And like, I feel like when I share this story, when I teach these courses, some people are like, because their families would never say something like that to each other. But what that tells me, of course, I'm not going to shoot my dad. Of course, I'm not going to do anything like violent. But what that gives me permission to do is to know that what he means by that comment is, if he were in a situation where he is not able to speak, he's probably going to be permanently disabled, he's on a ventilator, and the doctors are saying, look, we can continue this care, and he might live in a nursing home at best. Do you want to continue this aggressive care? Knowing my dad and hearing those words would just shoot me, I would be like, no. The man wanted to die naturally. If he could not, get up and, have a lot of dignity and be independent, he would not want this kind of care. And that is that pearl that comes out of that conversation. So I have not, we don't check all the boxes of like, do you want CPR? Do you want dialysis for 4 days? Do you want IV fluids, feeding tubes? Like all of that stuff, it's helpful, but what's helpful is the discussion around it and those comments that come out, those pearls, as I call them.
Yep. What else do you need, or what else would be helpful for you as a doctor to be hearing from your patient when they come in and you're having this discussion? What would help you?
Sometimes when patients are really unsure, I ask them, have they seen any deaths around them that look good or that look bad? And honestly, most people will be like, oh my gosh, my Aunt Gertrude, oh, I would never want to have, died like that. And I ask why. And they say, she was in a nursing home, had no idea who she was, and she lived for 10 years. And anytime anyone visited her, it was like a stranger, and it was heartbreaking for her children. And finally, she died after a long illness in the hospital or something. And so then we kind of, pick that apart. So that's helpful. Or sometimes they'll say, well, my mother had a beautiful death. She died at home with hospice. All of us were able to be there, and it was just so peaceful, and we all got to talk and say our goodbyes. And so sometimes when patients are not sure what kind of information to include in an advance directive, I like to help them think through some good and bad deaths they've seen and what makes them that way. And that helps sometimes tease it out. But I think people generally kind of know in their hearts whether they're the kind of person who would want sort of a natural death at home that's a little bit more painless, or to focus on pain control, versus the ones who are like, I want everything done. I want all the interventions. I want to live on this planet as long as possible. People kind of, I think, already know that camp that they're in.
Oh, yeah. Um, I'm curious for myself. So whenever a person has surgery or they go see another doctor, there's always who's your primary doctor, and you put down your primary doctor. And hopefully we have these conversations with our primary doctor. If something happens, if there is emergent, like how involved do you get to be being the primary doctor? I mean, do you even know about if a person has an emergency? I'm curious.
Yeah, that is a good question. Unfortunately, healthcare is so fragmented these
Yes.
days. And so when I have patients who go to the hospital who, and they're in the ER and there's bad things happening and it's fast, I'm usually not involved until either they're leaving the hospital or, I find out 2 weeks later from a discharge summary, unfortunately, when they have a follow-up visit. So that is unfortunately the most common situation. Sometimes I do have family members write to me, like on our online portal, and just say, my mom was admitted last night. This is what's going on. Mm-hmm. Or sometimes I even have patients themselves write to me. Oh, I was admitted last night with a fall and I have a broken hip. Or sometimes people call. So I may be involved, but at that point, it's more usually to support a family member who I know well from our pre-existing relationship of that person coming to doctor's appointments. And so that's really where the benefit of having a primary who has a relationship with you comes in, because then we can, we can share certain, like there's just like a trust there, I guess. And so sometimes, occasionally, I'll get involved with a hospital doctor, a hospitalist, call them, or I'll call the ER in advance if I'm sending somebody over. But yeah, in this, it's a fragmented system now. And so a lot of it depends on the relationship you've already built.
When a person comes to you to start talking about this type of stuff, should they be talking also bringing up current health issues that they're having? I talked about lifestyle a little bit when I gave my example of me being a cyclist, and you just never know. Are these some of the things that are important for you to know as a physician so you could have a real conversation with them?
I mean, I'd like to think that as their primary, I know, like, 99% of what's already going on in their health, right? I know if they have a serious illness,
Yeah.
say a metastatic cancer, I know if they have, some other chronic illness, heart failure, COPD, emphysema. So I don't know that they need to necessarily tell me about their diagnosis, because I would like to think I would already know, unless it's so obvious that something has changed dramatically and I am not aware of it somehow, because that does also happen, back to that, fragmented healthcare system. But for the most part, if there's just an anxiety there that I need to know, I mean, I can usually pick up on it very quickly with patients, like, oh, this is an anxiety, but it helps to know a specific reason. Like sometimes patients will come to me and they say, I have a headache and it started 2 days ago. And I'm kind of like, okay, this so far doesn't sound so scary. And then they'll say, oh, and my cousin died a week ago from a brain tumor. And so then it becomes like, we have gotten to the real reason you are here is because you are worried that your headache is a brain tumor because of the recent history. And in that case, honestly, I might go ahead and order them an MRI, like after 2 days of nothing scary, and just say, I understand that I'm really treating the underlying anxiety, but if this would put that to rest, we can do this test. And so same thing with advanced directives. Like if there's something big and underlying, I want to know about it. But for the most part, as a primary care doctor, I'd like to think I already know about their health conditions.
Yep. Now, on the advanced directive, there are those life-sustaining measures: CPR, ventilators, feeding tubes. And I know because of time, we're not going to go into a lot of detail, but can you give a high level? And I know also you have specific classes to really go into detail. So I just want you to go at a high level. So people, when they see these things on the piece of paper, one, they know what it is. And are there any concerns that you've seen or anything that you've seen with past patients that might help them make a more thoughtful decision about this?
Yeah. So yes, I have an online course. And this online course was born out of me teaching this material, dozens of times in life, and then just deciding to record it. And so it's on my website. It's 6 modules. Each one is about 20 to 30 minutes. On a specific topic. So there's one on the medical interventions, there's one on the advanced directive, MULST form, PULSE form, whatever your state calls it. So if somebody wants more information on those specifically, I do a deep dive on all of those. And honestly, it's a great course, and people always give me feedback that they learned so much that they didn't even know they didn't know. So so if somebody wants all the details, it's there. As far as just an overview, so I think sometimes it helps to just remember, an advanced directive is a document that names your medical power of attorney and your general medical wishes. And this is a document that everyone should have starting, at 18. Some state advanced directives do get into specifics about specific medical interventions like CPR, antibiotics, dialysis, and others are more general. Now, a lot of states have what's called like a MULST form or a POST form or a PULSE form. And these are medical orders for end of life care. And these are much more specific, like feeding tubes, dialysis, IV fluids, things like that. So it depends on what your state form looks like. It may not even mention specific medical interventions. But as far as like what the medical interventions are, if they're listed on either one of these forms. So overall, so CPR is basically a way to restart somebody's heart when it has stopped. So somebody basically is dead, right? They have no pulse, they're not breathing, or they're not breathing normally. And so CPR is a way to manually pump the heart. So that's where the chest compressions in. These are deep, aggressive chest compressions. You are compressing the chest down to pump the heart. So these are not ginger, like little, like, fluttering kind of pushes. These are big pushes to pump the heart, to get the blood pumping to the brain until ideally it could be restarted with medications.
And does it, because you're talking about it being aggressive,
Yeah.
many people, I'd say the most people don't, the ribs crack or the sternum
Yes.
because
If you were
it
doing
is.
CPR,
Yeah.
yes.
Okay.
Yes. If you were doing CPR correctly, you will probably break some ribs, if not multiple ribs. And the success rate of CPR is pretty low. So community CPR, so somebody passes away at home, somebody attempts CPR, the rate of survival long enough to leave the hospital it's around 5%. It's very, very low, right? Most people who get CPR in the outside world do not make it. And then if you're in a hospital and you get CPR, the odds are still not very good. It's less than, the numbers depend a lot on age and other health conditions. That's about a 20% survival rate to leave the hospital. And these are not people who are leaving the hospital to go back home and live a life. These are people who often are leaving to go to a rehab center or often a nursing home. So CPR in most cases is not a very successful intervention. There are life-saving or life-saving examples of that. I have an article on my website about Damar Hamlin, the NFL player who had a cardiac arrest on the football field a few years ago, and how he immediately got CPR and he had a beautiful recovery, although he will not go back probably to the same level of function that he was at before. So that's CPR. And then other things that you might be talking about with your doctor. And again, this is probably more on the MULS form or the POST form or the PULSE form than the advanced directive. But that form is much more specific. So other things you would talk about would be ventilation. And this can get very confusing. This is about being put on a breathing tube and connected to a ventilator. This is for people who have, bad pneumonia, COPD exacerbations, heart failure exacerbations. And this can be either temporary until the underlying medications or the medications can help long enough to get somebody safe and off of a ventilator, or it can be permanent. Some people who have, say, brain damage might be facing a scenario where they might be permanently dependent on a ventilator. So there's kind of two scenarios there with ventilators. And then dialysis is a means of cleaning the blood when somebody's kidneys have failed. So somebody goes on a dialysis machine, they're hooked up with an IV, they're on there at least about 4 hours, a couple of times a week, 2 to 3 times a week. Their level of functioning is very dependent on the frequency of these visits. And for those ones, people are most likely, conscious and making decisions. So some people I've had patients who have lived long, beautiful lives, who have advanced kidney failure, and they just decide that they will not do dialysis. And then when they are at the end stage of kidney failure, they might pass away within, a couple of weeks. So I've had patients like that. And that's beautiful too. I mean, I just want to say, like, I have a patient that comes to mind and I tell you that story, and he lived a long, beautiful life, and he played tennis until like 3 weeks before he passed away, because he was, he maintained his function until the end. Other interventions would be IV fluids or feeding tubes. This is also very nuanced. When you come to the hospital, most people are put on IV fluids because that's half of what the hospital does right away when you get there. No matter what you're there for,
Yep.
You're getting IV fluids. You're nauseous, you have a headache, you're pregnant, whatever. But in some cases, it becomes a life-sustaining treatment. So if somebody is not able to eat or drink, they need the IV fluids because they're not able to drink. And then eventually, after a few days to weeks, people will depend on feeding tubes, and that is surgically implanted into them. And again, this could be short-term, long-term. It really just depends on what's going on. And that's why this is such a nuanced conversation. So somebody who's had a stroke, who just is not able to safely swallow without aspirating, might have a feeding tube put in, maybe temporarily until function is partially regained, maybe not. Whereas the patient who is, catastrophically, neurologically disabled, might have a feeding tube more permanently if they're not able to eat. And then other interventions, Antibiotics. So that's a question sometimes, like, do you want to give antibiotics to somebody? And that's, again, like, sometimes patients just reach this is something that's hard to understand when you're young and healthy. You're like, of course I would have antibiotics. But sometimes patients reach a point where they've been admitted to the hospital, 8 times in the last 6 months for pneumonia or urinary tract infection, and they live in a nursing home and their quality of life is really low. And they might say, you know what, next time I get a UTI, don't bring me to the hospital. Don't treat with the antibiotics. Just let that be my cause of, just let nature take its course. Let that be my cause of death. So antibiotics, I usually tell patients, like, you would get that unless there's a reason to stop accepting that. Again, it comes down to quality of life, the litmus test. What are you trying to accomplish here? There's another question on most of these forms too about, would you even want to be transferred to the hospital? And that comes back to, like, that example that I just gave with the antibiotics. Like, sometimes people, they've been transferred to the hospital every other week for the last 6 months, and they just say, like, no more. Like, if something happens, just let me be where I am and focus on comfort. Maybe have a hospice consult come in, and that way we can, like, treat this at home and focus on quality of life. For the Maryland Advanced Directive, the Maryland, the MOLST form, which is a very detailed of that class of forms, is something is a blood transfusion. So would you accept a blood transfusion or not? There are some very specific religions, for example, Jehovah's Witness is always the classic one that comes up, I don't say always, but often do not accept blood products. So those people might have it very clear on their advanced directive or on their forms that they do not want a blood transfusion. Whereas for most patients, I would say just leave it open because you just don't know the scenario. Most blood transfusions are not done because of traumas. They're done because of chronic kidney disease, anemia, cancers, other reasons. And so I just say leave that one kind of like open when I'm talking to patients. But those are sort of the specific medical interventions at the end of life that sometimes our patients or families are faced with. One more is big seeming medical surgeries or procedures. So sometimes somebody's had a stroke and the doctors are offering a procedure to put a wire into the brain to try to remove a clot, or they've had a cardiac myocardial infarction, a heart attack, and they might have a blocked coronary artery. And so there's a question about putting a stent in to open up the coronary arteries. And so sometimes families are, faced with that decision of like, hey, your 89-year-old mother's here. She had a heart attack. We're going to go ahead and put we think she might benefit from a stent unless there's a reason to, that you feel that she would want something otherwise. So that's like the short list of things and the abbreviated description, but these are very nuanced. And I always tell patients, just focus on your litmus test, I would want to be kept alive as long as I am still able to blank, because that'll answer the question for most of these interventions. Like, do you want to do this? Well, would I be able to walk my dog? Would I be able to recognize my grandkids? Would I be able to live alone? Like, those are things that ultimately have the most sort of North Star in your life.
Yeah. I always tell people when you're doing the advanced directive, it's important to the conversations about quality of life with your, the healthcare representative and your family, because there's only so much that these 2 or 3 pieces of paper can really, it's not going to account for every scenario. So the person who is speaking for you will need to make decisions so that are off that paper. That are, now for those people that don't know, MOLST and POST means medical order of life-sustaining treatment or physician order of life-sustaining treatment. And that actually needs to be done by your doctor and it's put in your file. So this isn't something that you're going to be filling out. It's
Yes. Yeah, that's a totally different document and it's often confused with advanced directives. But yes, a MOLST or a POST form is exactly, it's a document that's intended for people who are at a high risk of ending up in the hospital or nearing the end of life or nearing the end of their illness. And it's a very specific document and it does need to be signed by your physician, or some states allow a nurse practitioner or PA to sign it. And so for that form, you would make it with your doctor. So I think that's a very your hand is held and you guys go through it together kind of a document. So I would tell people not to get anxious over it. Just know it exists and it's different from the advanced directive.
So sometimes people feel like their doctor the doctors are so busy. Their doctor's busy. They don't want to take that time. And then they might make the appointment, they come in, but they have even more questions. 15 minutes is going on. Um, is it okay for them to be like, okay, can I make another appointment to continue this conversation or go off and do a little research? Um, what are your thoughts about that? And I'm kind of asking permission. Is this okay? Because so many people are nervous to ask.
Yes. And I feel for everybody in this situation. I feel for the patient, I feel for the doctor. The reality for most of us is 15 minutes. And so um things you can do about that. So one is come in prepared, and that's where I mentioned like thinking about your medical power of attorney, reviewing the documents for your state, thinking about your litmus test, like coming in so that your doctor isn't spending time explaining what a medical power of attorney is to you, that you would already, have a pretty good handle on that. So coming in prepared can be very helpful, scheduling the dedicated visit. And yes, at the end, and understand that this is a series of conversations, when you have, it may evolve every couple of years depending on your health status. And so absolutely it's okay to not have every last question answered, to at least have more information to go back to your family and think about it. Maybe look at some of the resources online that I can talk about that are out there that are great. Um, and then coming back and finalizing things if you want. But also a lot of times these forms in most states don't actually need to be signed by your physician. It's just, did you get your questions answered?
Yep.
And honestly, most of the advance directive is a conversation you have with your medical power of attorney, not necessarily with your medical decision makers, not necessarily like the doctor himself or themselves. Like that might be if you have specific clarifications.
Two offshoot questions. The first one you kind of mentioned, when should people revisit this with their doctor? How often should they revisit and rehand the doctor the advance directive? Here you
Yeah.
go.
I think I would say at minimum, you should revisit for yourself every 5 years and just look over and see if there's anything worth that you think needs to be updated. And then as far as when to actually update it, that would be if there's a significant change in your wishes, right? If that's because of your medical illness, or maybe the person you chose as your decision maker has passed away, and so you want to change that person. So updating it, reviewing it, and then yeah, you like the actual document only needs to be changed if your preferences have changed for whatever reason. And so you don't necessarily it's not like a checklist that you need to update every 5 years. The doctor, it's more just like, that's probably a good time to just look at it and say, should this be updated? Yes or no?
You mentioned before the medical systems how how fractured it is, and so if I talk to you as my primary and I hand you this piece of here, can you put this in my file? How
Yeah.
do I know? How can we be sure that other doctors are going to see it and it's in everyone's
Yes.
file?
Yes, this is a great question. So what do you do with your advanced directive when you finish it? So I joke that your advanced directive should be like glitter, right? Like it should be the kind of thing that it's like everywhere. Like no one can get away with it. You're like 3 days later, you're like, oh, there's still glitter on in my jacket.
Yep.
So what I think what you should do when you complete your advanced directive is you should give your doctor a copy and they can scan it in their system. You definitely want your medical power of attorney and anyone who may be involved in your decision making to have a copy. The worst place for your advance directive is safe in your safe. Patients always, oh, I have that all locked away in my safe, or my attorney has that. You want to document that at 9 o'clock on a Friday night, if somebody calls your emergency contact and they say, you're in the hospital, um, do we have an advance directive, that person can produce it pretty easily. So definitely scanned all over. Everyone should have it. People in their house should know, where it is. Your attorney can have one. Absolutely. It may not be always very accessible. And then the other thing, there's a great resource, My Directives. MyDirectives.com is a website where you can make a free online advance directive, and many states subscribe to a system where this is now available to them in real time in the hospital. So that's another online resource that people can use, and you can even scan your own advance directive there. And that's really probably the most sort of like universal way. But the big thing is that you've had conversations with your decision makers. they know what you want, and they would know where these documents are if needed.
Yeah, I tell people put it in your Google Drive and give everyone you love access to, like, send them the link to it. So, because if I'm out having a nice dinner, my parents want to, they need something, I'm not going to be carrying it, but I
Right.
can get to it on my phone. I'm carrying my phone here,
Exactly.
and you're going to laugh. You will laugh at this, maybe. I don't know, but so I went in for my colonoscopy, and the first thing I did, I was like, here's a copy of my advance directive, and the doctor kind of laughed a little bit. I said, I know nothing's going to happen. But this is a new you're my new doctor. This is a
Yeah.
new, I just changed hospitals. I want to make sure that you have it, just as an FYI, even though I know nothing's going to happen. But he kind of
Yeah.
laughed. Like, this is the first time I think that someone actually came for that simple procedure, right? Where you're just
Yeah.
being twilighted. But I'm like, I'm not making any chances here. I'm not taking any chances.
Yeah.
It was
No,
pretty
I mean,
good.
I think there's a lot of people trying to work on this, how to make advanced directives just more common. And so there's other, you mentioned, PDF versions, emailed versions,
Yep.
drive versions. There's legacy planners out there,
Yep.
that have, entire basically like
Platforms.
portals where
Yeah.
people can access this stuff easily. Um, I spoke with a company called Medeo, and they are into video advanced directives, and in regionally they're like all the EMTs have access to these. So people are working on this problem. Unfortunately, right now it's still very much like a pen and paper kind of issue.
Yep.
But I do think having electronic versions, it does help make them more accessible.
So one last question. These pieces of paper we've mentioned before, they're great, but they're just two sheets of paper. There are a lot of things that are going to happen that aren't covered in the advance directive, which is why it's important to have one or two people called out as your healthcare representative. Most people miss talking to their healthcare representatives or their families because this is a tough conversation. Do you know any resources that would make it easier for people to start these conversations, not only with their loved ones, but even with their doctor, so they know how to show up?
So when people say resources, a lot of times, like, people's eyes glaze over, but these are really helpful things. So off the top of my head, 4 things come to mind. Depends on your personality. So one, if you really want a step-by-step how to get started, I have on my website a free step-by-step guide to making your advanced directive. And within there, I have all the links that you would need to navigate this on your own. And then I have my online course if you want a little bit more of a personalized, I guess, touch to that. Now, within, and I mentioned these in my step-by-step guide, there's 3 resources that are really good. So one is, if you're kind of if you see the humor in the ordinary, there's something called the Death Deck, and these are cards. It's amazing.
Yeah.
Where you can basically, they're almost like playing cards that you would play with, and you can have a lighthearted conversation with your medical decision makers or with your family. And it's things like, if I had to be buried with 3 items, what 3 items would I have? But some of them are more lighthearted. Like, if I had to haunt one person, one celebrity for my life, who would it be? So it gets you going and sort of like juices going in these conversations. So the Death Deck is one thing. The other 2 resources that are much more serious resources, that not more serious, but one is the Conversation Project. So this is a not-for-profit group that has a website, the Conversation Project. If you Google it, you'll find it. And they have a starter kit of how to approach this conversation with those around you. And it's a very user-friendly, not intimidating document at all. And it just has sort of questions to get you going and to talk about with your loved ones. I really like the Conversation Project for people who don't even know where to get started. And then there's another guide that I often send people to, and this is really good for your practical people. Like, my background is in engineering, and I just, sometimes you just need those practical examples. And so this is the Cedars Sinai step-by-step guide for completing an advanced directive. And what they have on this guide is, if you download it, you can read it. It's free. And it has you mark 1 through 5 on how important something is to you. So, for example, I have it in front of me here, being able to get out of bed. 1, not important. 5, extremely important. And here another example is being able to move around without somebody's help. Another example is being able to think clearly. And again, that goes from 1 to 5. And I think by doing this exercise on your own and then talking to your medical decision maker, questions come up and things come up. And that's where those pearls come out that I was talking about earlier, where you can really be like, oh, I remember we talked about this and my mom really didn't want XYZ. And those kinds of conversations are so helpful. And if you're doing this, say as a couple, like if you're doing this with your spouse and you guys are making your advanced directive together, you could fill this out and have a conversation. Oh, I didn't know you would want that. Or oh, wow, I never thought that, that was so important to you, but now I do know that. And so those are the resources. So 1 would be my website, 2, the conversation guide, 3, the Cedar Sinai, and 4 is the death deck cards. Between those things, I think you will be very, very, very knowledgeable in advanced directives.
Yeah. All 3 of those are excellent resources because I've used all 3 of them, and I'm really partial to the death deck. It is so
funny.
much fun. It is really fun.
Yeah, it's a good one. And you can do it with young people and old people, and it's a good way to not make it non-intimidating.
Yes. Yes. It's the charades of the death deck or of the death world, right? It's really funny. So wonderful. Well, Eleanor, thank you so much for being on the show and for sharing all of your wisdom. How can people, you mentioned your work, how can they actually get in touch with you, and where is your website? What's that URL?
My website is advanceddirectivemd.com. Okay. And you can find me on Instagram by the same handle, Advanced Directive MD, and also on Facebook.
Thank you. Listeners, conversations about advanced directives don't happen on their own. They take preparation, courage, and honesty. The more you talk about what matters to you with your doctor and with your family, the clearer it becomes. Don't wait for a crisis. Start small. Take 1 step and give yourself and your loved ones the gift of clarity. Thank you for joining us. If you have any questions, please comment below or reach out to me directly. And if you found this conversation to be helpful, please like, share, comment, and subscribe. This is Traci Arieli from Comforting Closure, wishing you peace and comfort in your journey. Until next time, take care.